Okay, we're going to do an overview of pneumonia today. We'll talk about community-acquired pneumonia, which is shortened CAP, typical and atypical strains, hospital-acquired pneumonia, opportunistic infections, aspiration or ventilator-associated pneumonia, VAP, and healthcare-associated pneumonia, which is HCAP. There's a couple terms I want to cover before we get going here. Remember, itis is inflammation. So when we have bronchitis, that's a larger airway inflammation. Bronchiolitis is a smaller airway inflammation. Pneumonia refers to an infection in the lung. An upper respiratory infection, or URI, is generally what we're talking about is the larynx or above, is that separation. So URI versus pneumonia, upper respiratory infection is larynx or above. Pneumonia then is infection in the lower airways. Pneumatocele is a thin-walled structure that's filled with air. A lung abscess is an infected fluid-filled area. Cavitating lesion occurs in patients with tuberculosis where there's this kind of lung-eating tissue. An MDR is a multi-drug resistant organism. So what do you think bronchiolitis would look like on an x-ray? Again, this is inflammation of the large airways. You really don't see much on x-ray. Why do we take it? We take it because we're worried about it being pneumonia. What we're seeing here is vascular markings, not infection. Here's a pneumatocele, so we see this large black air-filled, so again this is a thin-walled air-filled structure. Is it fluid? No, because it's black, so it's air. This could be caused by some cavitating lesion. Here's where it shows up on the actual x-ray. A lung abscess, if we look at these on x-ray, on this PA film here we see it's rare to see kind of a straight line that we see here. We look at the lateral and it's very prominent that we see this air fluid level, and that would be a lung abscess. So how do we classify pneumonia? There are several different ways. One is community-acquired pneumonia, and this is generally secondary to some other disease. Most of these organisms are gram-positive, but this is where community-acquired, somebody gets a cold, they go around to others, like a retirement center or senior centers or daycares. Concomitant means something else is going on, like COPD, bronchiectasis, cystic fibrosis, some sort of lung cancer. Generally, this is a streptococcal strain or a staphylococcal. Most of these are bacterial infections that are spread through the community where people are in close quarters. Hospital-acquired then is 48 hours after admission, also something else going on. And most of these are actually gram-negative organisms, such as E. coli enterobacterial that's in the gut. And what happens here is patients are in the hospital after they've been in for 2 days. They wind up with fever, crackles, productive cough. Their oxygen saturation starts to fall. They're coughing up secretions. What we wonder when we first see that fever is it a urinary tract infection or pneumonia? If somebody has a fever, those are the two main things we go to first off. Then we have VAP, or ventilator-associated pneumonia. These are in intubated patients, so it's an endotracheal-associated pneumonia, where they're being suctioned and we're introducing secretions with this lack of a good natural barrier system. So this is pneumonia that occurs 48 to 72 hours after endotracheal intubation. How would you know the patient had pneumonia? Again, a spike in fever, we look at their x-ray, some sort of change. Then we have HCAP, or healthcare associated pneumonia. What's the difference between hospital acquired pneumonia? The difference is this is related to healthcare. Any patient who was hospitalized in an acute care setting for 2 or more days within the last 90 days of infection, or somebody that comes in to the hospital maybe for dialysis 3 days a week, or a visitor, or a healthcare working, so you're exposed to the healthcare setting and you wind up getting pneumonia. So typical community-acquired pneumonias, the biggest one we're going to focus on is streptococcal pneumonia. Other ones are listed here, including Haemophilus influenza as being somewhat prominent, and Staphylococcus aureus also there. Sometimes community-acquired pneumonia has been referred to as the old man's friend. This refers to an elderly patient that's battling another disease. They get pneumonia, and the pneumonia is actually what kills them. But in essence, they're actually people that are kind of ready to die. They want to die. If they want to protect themselves, they can do something like get a vaccine, and again, during cold and flu season, be really diligent about getting a good night's rest, eating appropriately, going in the grocery store, wiping the carts off with those sanitary wipes that are provided. Atypical community-acquired pneumonia. This will occur where we see a large outbreak of pneumonia amongst a certain group. These have come out in the military, or they can be common in college dormitories. And this is, the organisms here can be something like Legionella, chlamydia, mycoplasma, are some of them. So Legionella has an interesting story behind it. It's an organism that lives in water, and in the mid-70s it got its name because there was these Legionnaires, which is a service organization of men. They had a convention in Philadelphia. They were staying up late like people do at a convention. They drank, they ate bad, and turned out the water was contaminated, and all these men from this service organization came down with community-acquired pneumonia, and they determined the organism was from a Legionella from the water within the convention center that they were staying in being infected. So it causes pneumonia. It can show up in the summer in some swamp coolers. They've been found to harbor this illness, or even some shower heads. Shower heads sometimes will not drain all the way, and so they remain moist, and so this warm, moist environment where this organism likes to live. It's rare for us to get sick from this. We might be exposed to it from a shower or somewhere, but we don't get sick because we have a healthy enough immune system that we're okay. There can be opportunistic pneumonias. These are things where it really waits until our immune system is weak, and we may get exposed to this, and then our immune system weakens, and then it affects us later. These are organisms like Pneumocystis jirovecii, or PCP. You'll hear of this primarily around patients that are HIV positive. Cytomegalovirus occasionally shows up. Aspergillus and cryptococcal are actually fungal infections. Mycobacterium tuberculosis, we've heard of that because of TB. So the patients that wind up getting these opportunistic pneumonias are those, as I mentioned, HIV patients, patients receiving chemotherapy, patients maybe with bone cancer where they're not producing adequate white blood cells, or those patients with leukemia. So typical hospital-acquired pneumonia and healthcare-associated pneumonia. They're mostly anaerobes where they don't require oxygen to breathe. They can be gram-positive or gram-negative organisms. Key ones here are Klebsiella, Staphylococcus, enterobacteria from the gut, Pseudomonas aeruginosa, Estro coli, and healthcare associated pneumonia also includes these multi-drug resistant strains. So the most common multi-drug resistant strains are listed here. Pathogenesis of pneumonia. So what happens in the body when we get pneumonia? So there's basically 6 ways that we can come in contact with it, and they're listed here. I can inhale infected particles. So I can inhale the flu from somebody else. I might inhale diphtheria particles. They can be aspirated either from, they can be growing in our mouth with poor dental care, or aspirated from patients on a ventilator. We can have direct inoculation of the organism into the lower airways. Doesn't happen very often. It can be spread from adjacent structures, meaning a patient has a sinus infection. Those sinuses drain in the back of the throat, and then those then wind up in the respiratory tract. Very rare, but infection can be spread to the lungs through the blood. So somebody whose blood is infected, we call that sepsis. That sepsis can run into the lungs. It's more commonly that the lung infection leads to a blood infection, generally not the other way around. Or it can be a reactivation of a latent infection, and this is what happens with tuberculosis, mycoplasma, and fungal infection. So clinical manifestations of community-acquired pneumonia. The unique symptom here really is this sudden high fever followed by a really, really bad chill. Tends to be more affected in older people or the very young. Atypical onset then is this gradual fever, headache, diarrhea, and a cough with minimal production. So pneumococcal and streptococcal pneumonia. This is another organism that can cause community-acquired pneumonia. The factors here that they look at that help differentiate this are the patient describing a kind of a pleuritic chest pain, and the big difference here is then this rust colors or kind of a red orangish colored sputum. If somebody has aspiration pneumonia, this is either again ventilator associated or associated with a stroke. In stroke patients, remember, sometimes they'll lose that gag swallow reflex, and if we think about our reflexes, if you have the gag reflex, the pharyngeal reflex, you have all the others below. So that laryngeal is below that, where we would close our vocal cords if some aspirate came in. Tracheal reflex would cause us to cough, along with that carinal reflex, it would also cause us to cough. We lose those reflexes again from the top down and regain them the opposite way. So with aspiration pneumonia, the patients tend to have, or we will notice, a really foul-smelling breath. And then we would want to say, is there any reason maybe that this patient has a weaker, some protective mechanism that's been lost? Symptoms of hospital-acquired pneumonia is this new onset of fever in the hospitalized patient. So they've been in the hospital more than 2 days, we mentioned that. It's most frequent in those patients that are already on a ventilator. We see this new infiltrate showing up on the x-ray, and they have purulent secretions. Purulent really is going to mean anything other than clear. We're going to call purulent. How do we diagnose it then? We take a clinical history. We ask the patient, what have you been doing? Where have you been? What have you been exposed to? How we really tell then is by the x-ray and then by blood cultures. Cultures, we're going to do both sputum and blood. We're going to look at a complete blood count, checking for an increase in white blood cells. The BAL, B-A-L, is a bronchoalveolar lavage, where we do a wash and we see what's in those bronchial fluids. Occasionally they'll do a pleural fluid analysis to see did that infections move to another place into the pleural space. There's a C-reactive protein. It's a marker of inflammation or infection that's sometimes captured. And arterial blood gases are occasionally drawn in those patients where we're seeing low oxygen levels. And so they'll want to look at the PaO2, and oftentimes the body is trying to compensate, and so the CO2 is also low because they're ventilating so much that they're blowing off the carbon dioxide. So what do we see on the x-ray then? We see this path of infiltrates, and we're really looking at either some sort of lobar consolidation that tends to be bacterial. So we see in a certain lobe, is there some consolidation? In bronchial pneumonia, those tend to be bacterial. If we see a pleural effusion, that tends to be also a bacterial infection. We look at the interstitium area for infiltrates. Those tend to be more viral. And then we're going to look at these, if there's any cavitations. The cavitations lead to either looking at, is this a fungal bacteria or a microbacteria? Risk factors for community-acquired pneumonia, or we mentioned the elderly, those with other comorbidities, again, such as diabetes or hypertension or heart disease or what else. They tend to be male, and nursing home residents are at higher risks. Anything that interferes with our host defense is a risk factor for those patients with hospital-acquired pneumonia, such as sepsis, diabetes, or any sort of malignancy. So something else is wrong with the patients. Then we put them under all this stress. And to some degree that stress, if you think of being under stress, patients produce more stomach acid. We give those patients antacids to overcome that, and sometimes we change that overall microbial balance within our patients that leads them to having a higher risk for infections. Then we also do things that possibly facilitate exposure to large numbers of bacteria. We talk a lot about using a sterile technique, but we're talking about that because we know we may be entering body structures that should be sterile that we may infect, such as an endotracheal tube or an NG tube. Again, NG tube is definitely not sterile. They could be on prior antibiotic therapy that they don't tell us about, and we can have this neutralization of gastric pH. So how do we treat this? A lot of times it's empiric, meaning we're going to give our best guess. So somebody comes into the doctor's office with a 68-year-old, comes in with rust-colored sputum, a high fever that came on strong. He also has a diagnosis of diabetes. He's coughing and coughing throughout the office, and the doctor's probably going to say, I think you have community-acquired pneumonia. Here's an antibiotic. If you're not better in 24 hours, give me a call. If they come back 24 hours later, we're going to do an x-ray, a culture, and see what's actually growing. Definitive treatment. That's where definitive treatment means we've got a culture. We know the organism. Empirical treatment means we're going to give it our best guess from what we've seen in the hospital recently, for what we've seen in the community. Here's what's been going on. And it can be a treatment of combination antibiotics where we give something that's going to kill both gram-positive and gram-negative organisms to kind of knock out everything here. When we talk about resistant organisms, here we're talking about, again, we've mentioned this, methicillin-resistant Staph aureus, which is a gram-positive organism. We can have vancomycin-resistant enterococci, and multi-drug-resistant pathogens, those that will be problematic with C. diff and tuberculosis. So what about prevention? Prevention is the best medicine we want to think about here. This is where hand washing becomes very important. Getting a flu vaccine in patients that are at higher risk for pneumonia, getting the pneumonia vaccine. In the hospital, we try to keep patients, especially those that are at risk for aspiration, in a semi-erect position. So they're going to be in semi-Fowlers or high semi-Fowlers. We attempt to do subglottic secretion aspiration where we're suctioning above the cuff, so any of those secretions from the oral cavity that may be infected don't fall below. Infection control and surveillance, so we're watching within the hospitals to see what's happening. Isolation of patients with any type of resistant organism, so those are the isolation patients that you're seeing. and careful handling of respiratory therapy equipment from patient to patient to make sure we're not spreading this.